All right, so moving on. Now we're going to talk a little bit more about advanced imaging. I'll throttle it down a little bit because there's not nearly as much content. So, oops, let me get this, and there we go. I still don't have any financial disclosures in the last 15 minutes. So what are some of the objectives? I made these pretty obtuse. Review radiological anatomy, which we'll talk a little bit about. Discuss, and here's the big one, the advantages and disadvantages of various imaging studies. And then really the third one is when and why to use contrast, because that seems to be one of the biggest questions and concerns that folks have. And certainly if there's other things, I want you guys to shout it out, or if you want to type it, I can still see the chat box. So we can do that either way, whichever's better for you all. So as we just got done talking for several hours about plain films. Plain films are still always a good start. The exception of this rule is trauma. So this isn't a trauma talk, but we're going to talk a little bit, about advanced imaging. But starting with plain films in the absence of trauma is certainly good. And I'll be honest, most insurance companies won't let you do anything until you document some imaging by plain film. Even if it's a stupid idea, they still want you to have some plain films as part of their protocols. So that's one thought. It's still a good initial test, again, in non-trauma, excellent bony details, very cheap, even in outpatient centers. It's very low cost to the patient, very minimal radiation exposure, and we'll talk a little bit about that as well. And it's helpful to utilize with the physical exam to figure out what is my next step. That picture I got on the right here, just looking at this is an interesting picture, and I show this to a lot of my students because this was a guy who actually fell off of a retaining wall about 3 or 4 feet. So it wasn't a high-grade trauma, but he fell and his back was killing him. And he came in with this x-ray. And if we look at this x-ray, yes, he has multi-level degenerative changes, and one could easily surmise that, well, he just exacerbated his underlying degenerative changes. In actuality, if we count these up, this is 5, 4, 3, 2, 1. L1, this guy actually has an inferior end plate compression fracture. So, just on the plain films alone, we can say this guy's got a fracture. Secondly, most of you are probably about pulling your hair out going, doesn't that idiot see that big AAA? And yes, indeed he does. He has a AAA. We saw one earlier. This is another one. If we look down here, we see what the aorta should look like. When we get up here anterior to the L3 vertebral body, we see this marked dilation here. Now, is that why he's in our office today? No, he's here because he broke his back, but he clearly has a AAA here. So again, plain films can be very, very helpful. And they certainly sometimes tell you things you didn't want to know, but yet they can be life-saving findings. So it's worth paying attention to those kind of things. What are some of the disadvantages? Well, they're lousy for soft tissue. If we look at this x-ray, I would propose or challenge anybody here to show me the muscles, show me the fat, show me the organs, show me, ligamentous structures. You can't because you don't see them. I hear over and over again from patients, oh, they did an x-ray and they told me I had a herniated disc. Not on an x-ray they didn't. Now, clinically, can I be suspicious of a herniated disc? You betcha. I mean, my physical exam and history alone could make me think that very, very quickly. But looking at an x-ray, we don't see the disc. We see the bone and we see the disc space, but we certainly do not see the disc, nor do we see the nerve roots or the spinal canal or any of the supporting ligamentous structures. So another way to think about this is ACLs. If a person was running, had a sudden deceleration injury, clinically, they're giving you a good history of an ACL tear. If they had a positive drawer test and a positive Lockman's test, you could certainly be considered that this or be concerned about an ACL tear. If you get an x-ray of that same person, you don't know if they have an ACL tear, right? It's soft tissue. So x-rays are great for acute or chronic bony injuries, fractures, things like that. Even avulsion injuries can be discerned. But again, lousy for soft tissue. So when we start talking about advanced imaging, one of the things that we need to understand is that when you get advanced imaging, most of the time you're going to get different views, axial, sagittal, and coronal, not just an AP lateral like you do with a 2 view in plain x-ray, but now you're getting both the X, Y, and Z axis. So sagittal plane, coronal plane, and axial plane, which is diagrammed out pretty well here. I always tell patients, hey, when I'm talking about axial imaging, it's as if I took your head off your shoulders and I'm looking down your spine, and they understand that a little better than saying axial. Sagittal is I'm looking at you from the side and I'm pulling it away like a loaf of bread. I'm taking each piece of the loaf of bread away and I'm going step by step by step from left to right or right to left, depending on where I started. And then coronal imaging, of course, front to back or back to front. Hey, I'm peeling you away from your nose towards the back of your head or from your belly towards your back. And that's the same regardless if you're doing a CAT or an MR. So it doesn't matter which one you're doing. Those types of nomenclatures will be utilized, axial, sagittal, and coronal views. So you don't have to know different ones for different things. That's for those primarily MRI and CT. And then occasionally you'll get what they call 3D reconstruction. Right now that's limited to just CAT scan. 3D reconstruction is wonderful for bone detail. As you see, I gave you an example down here of a really nasty proximal femur fracture. Kind of really helps you spatially orientate where the hell that fracture is. On 3D reconstructions, you can actually spin them 360 degrees. So it really gives you a good idea of anatomically what's going on from a bone perspective. It really doesn't do much from a soft tissue perspective, but from a bony perspective, it's really slick. It's really slick for like calcaneal fractures, proximal humerus fractures, things like that. It's really slick to get a good idea of how nasty is this. Now, in a primary care setting, do you have to worry about all that? No. Very rarely are you going to be asked to do all that. But if you're in a subspecialty, or even in a primary care position, I want you to understand what the heck the differences are. What do they mean? Why do you do it? That kind of thing. So CT. How is a CT obtained? Well, it's done by taking lots and lots and lots, hundreds of x-rays in a rapid succession, and then utilizing those through a computer program to give you the cute little pictures that you get. One of the big problems is that there's significant radiation exposure, anywhere from 10 to 100 times more radiation exposure than a plain X-ray, because you're getting hundreds of X-rays at one time, and it's doing it as the X-ray beam spins around that gantry. It's shooting hundreds and hundreds of films, and then that information, those various densities, are then put into the computer screen to give us the pictures that we see. As I said a moment ago, you can get axial, coronal, sagittal, and now 3D, which is really slick through CT. Well, what are some of the indications? You want to correlate with plain film abnormalities. Does this person really have a pars defect? Does this person have a trauma? Do they have a fractured spleen? What's going on? And yes, excuse me, larger organ, you can absolutely get some decent detail. However, it's not great for small soft tissue, and I'll get into that a little bit more here in a minute. Advantages, you can look at a lot of structures in a very quick time frame and with really good high resolution and no claustrophobia issues. You're not going to have a patient that says, oh, I can't get a CAT scan because I'm claustrophobic. Usually if they're telling you that, they're mistaking that for MRI, or they don't know the difference. It's one or the other. What are some of the disadvantages? Significant radiation exposure. And so for patients that only had a CT once every blue moon or every couple of years or every 5 or 10 years, not an issue. However, you get some of these patients who are professional patients and they're getting their head CT, they're getting their back CT, they've got a CT of their abdomen and pelvis because of this or that. So you got to think about that. One of the jokes I read before in one of the medical journals, it showed a CAT scan and it said, finds cancer or causes cancer. And it's funny, but it's not. I mean, it's kind of one of those, hey, are we unduly exposing some of these folks to radiation that really shouldn't be? Some will suggest that if you flew from New York to LA that the amount of radiation you get in the plane is similar to a chest x-ray a year. So, I mean, we're all getting some degree of radiation exposure. It's all around us, but in small amounts, it's never a big issue. But when you start throwing that on top of CAT scans and imaging studies that are radiation utilized, then you have to be a little bit more careful and think about the risk versus the benefit. When we look at CT, as I've said 100 times now, that has great bony detail. It's okay detail for soft tissue in larger areas. So when you say, well, wait a minute, why do we get a CAT scan of the brain if it's no good for soft tissue? It's a large area. You can get an idea if there's anything obvious going on in terms of bleeds. However, you're not going to find a 2 or 3 millimeter abnormality on a CT. You're going to pick that up on MR when you talk about brain. If you got a splenic laceration, you're able to pick that up because it's a larger organ. So again, CT has its limitations. And it's great, again, for bony detail. It's okay for larger soft tissue areas. So to make this point a little bit more, it's a very lousy test. If you had a torn meniscus in your knee and you went and got a CAT scan, all they're going to tell you is, hey, there's no fracture in the knee. There's no fracture of the patella. There's no fracture of the distal femur or proximal tibia. They cannot tell you, nor could I, hey, they got a meniscal tear or not. The tissue's too small. Same thing with the labrum in the shoulder. Same thing with labrum in the hip. Same thing with tendon injuries or soft ligamentous injuries. So yeah, hopefully that gives you a little better idea on CT in terms of application and utilization. When you look at a CT scanner, I threw just a picture of one down there. They got a nice big open gantry and it's narrow. So the patient basically lays on the table, they slide into it and it moves back and forth. As that patient is laying there, this thing right inside here spins around and around at a very high rate of speed. As it's spinning around, one side where my cursor is shooting an X-ray beam. The other side where my cursor is catching it. But that's constantly spinning around the patient. So it's constantly shooting all the way around and catching on the opposite side. So as the patient slides in and out, that CAT is constantly spinning, shooting pictures, and then sending it to the computer. And then the computers are then regenerating those pictures to give us some of those cool little images that we're able to look at and utilize. So just for sake of nomenclature, CAT's computed aggregate tomography uses radiation, lots and lots of pictures compiled by a computer, very, very commonly available even in rural settings. They're not very expensive. Outpatient CT in our area is probably about $200, $250. Excellent bone detail. If you're looking from a GI perspective or abdominal standpoint, oral contrast is usually helpful to identify the large and small bowel. Think about bowel as usually, unless there's a lot going on in there, it's usually pretty compressed. It's not all dilated open. So it's pretty hard to see anything obvious without oral contrast. So throwing some oral contrast in there is a good idea to try to get a better picture of the intestines. Certainly if you're looking for things like diverticulitis, small bowel obstruction, things like that, oral contrast is absolutely beneficial. As I said 100 times now, lousy for soft tissue, small soft tissue, lousy for neurologic detail, such as looking at cervical disc, spinal nerve roots, things like that. You're not going to see them, and I'll show you examples of that here in just a minute. Just like X-ray, air is black, bone is white, and then you have those shades of gray. So if you think about it the same way you do with the X-ray, you're in good shape as far as how to interpret this. And so contrast or no contrast, when we're looking at CT, one of the first things you got to make sure of is their kidneys okay? Is their creatinine reasonable? Most places, and this is not a hard, fast rule, it's a generality. Typically, if the creatinine's less than 1.5, you're probably in pretty good shape, or if the GFR is greater than 45, you're probably okay. The second concern is, do they truly have a contrasted allergy? Some folks will tell you, oh, I'm allergy to shellfish. Well, that doesn't mean you're gonna have an allergy to contrast. On the flip side of the coin, if a patient tells you, look, they gave me contrast and all of a sudden I quit breathing and I didn't know what happened, I'd be pretty worried about that. I don't get real worried if a person says, oh, I itched a little bit after that. Oh, I think I might have had a hive after that. Okay, great. I don't get too worried about it. I might say, punt that to radiology so they know. In some cases where there's a reasonable allergy, but not necessarily anaphylaxis, in contrast is just really needed in order to get the correct study. We talk about using pre-medication. Each hospital has its own protocol. Locally, the protocol around here is 32 milligrams of prednisone 12 hours before, and then repeat 2 hours prior to the study with 50 milligrams of Benadryl at each dosing as well. Now, that may be different with your facility, so it's worth talking to the radiologist about. A lot of them in the litigious areas that we all live and work in, sometimes they're really going to push against it. Unless you absolutely have to have it, I don't fight them on that, and a lot of times I'm going to say, look, this is what my differential is. This is what I'm worried about. Is there a different study I can do? And working with radiology and certainly in concert with them is a good idea. I think, if you got radiologists who won't talk to you or work with you, oh, you're just an NP, then go somewhere else. Take your business elsewhere. I can tell you that the radiologists in my area and I have a very good relationship, even in the outpatient settings as well as the hospital settings. And because at the end of the day, they get paid the same to read my CT as they do my attendings or one of the other folks. And if you don't want to help me, I'll find somebody that will. So. But most of the time, radiologists are pretty good about stuff. You just got to tell them, hey, this is what I'm looking for. This is what I'm worried about. What would be my best test? Or, hey, I'm worried about this person's this or that, and they have X, Y, and Z as comorbidities. What do you think? And you'll get the feel of that after you do that a few times, because sometimes they're going to have a better idea. Other times they're going to scratch their head and go, boy, you're right. I don't really know. And then it is tough. I mean, there's not always a good answer, but what's the best answer for the situation that you have? When in doubt about the benefit of contrast, ask the radiologist, hey, I am worried about A, but their creatinine's really kind of on the fence post. Can I get by without contrast? And they'll give you a good idea of, yeah, Chris, I can tell you this, this, and this, but it's not as good as if we had it or didn't have it. So then you have to weigh out the risk versus the benefit, and even talking to the patient about it too. But most of the time, there's a reasonable answer. The other thought is, if you got patients that have borderline creatinine functions and they have a nephrologist, which most of them will, is I'll call nephrology. There's one or two of them around here that are really good guys, and I'll just call them up and say, look, this is what I got to do and this is what I need. What do you think? And they'll say, oh yeah, you can do that, but just hydrate them first with some IV fluids, or hey, hold their this or that, or hey, do this and then check their creatinine a day or two later. They'll give some direction on that. Again, collaborative effort. This is for the good of the patient. It's not a Hemmer show. It's not a nephrology show or a radiology show. It's hey, what can we do collectively to get a good outcome for this patient and get the answers that we need? Contrast is always helpful when you're worried about infection. If you got a patient that you're worried about cellulitis, you're worried about appendicitis, you're worried about an XYZ-itis, contrast is almost always going to help you. So there's very few times where it's not going to help you in those scenarios. So if you're worried about infection and there's not a contraindication, use contrast. The other thing to think about is sometimes you say, well, I don't know, it could be this, and it could be this. I'll just get contrast and get a CT. Well, one of the things you got to remember is when you give contrast, everything's going to appear very bright white on CT contrast. And so if you're worried about a kidney stone and you throw a bunch of contrast in them, you just lost the ability to diagnose a kidney stone, because you are not going to see a stone if there's all kinds of contrast in the colon and other places. So you really got to kind of narrow down what your differential is. And that can be tough, because you're kind of wondering, well, shit, do I have a appendicitis? Do I have a diverticulitis? Or could it be a stone? And two of those cases, contrast can be helpful. In one of those cases, it's detrimental. So, it gets a little tough. That's where you have to really kind of narrow down your working diagnosis and then think about your differentials. And if you're really still in a pickle, sometimes talking to the radiologist to talk it out can help give you a little direction, because again, they're the guy or gal that's going to be reading this thing and saying, okay, you do have this or you don't have this. And sometimes they'll tell you, you know what, if you just do it this way, I can give you your answer. So, again, collaborative type approach. So I talked a lot about bone detail. This is just a picture of the cervical spine. And what I want you guys to look at is, this is that C1-2 articulation that we were talking about earlier this afternoon. You can see just beautiful detail, bone detail. We see disc space, but you really don't see disc. If we look at the sagittal image on the right here, we see bone beautifully, but you don't see the disc. If you look back here, this big open area, there's a spinal cord in there. Well, if you're looking at a CT, I don't know what the hell's going on in that spinal cord. I can't see it. So CT looking at it from a cord perspective is a waste of money. You don't see anything. And look at the brain. Do you see the brain stem or the brain here? No, you don't. It's a waste of money. You just don't see good detail if that's really what you want to know soft tissue wise. Don't spend your money on a CT. This guy or gal could have a huge herniated disc in their neck. I might have clinical reason for it, but a straight CT is not going to show me a herniated disc. And we'll talk about what do you do if you can't get an MR and you're worried about that. We'll talk about that in a little bit. But I wanted you guys to see the detail of bone versus the neurologic detail or the soft tissue detail, because it's really a big, big difference when we talk about things from a spine perspective, especially. CT, again, we see just phenomenal 3D reformats. And again, looking at the bony detail is just incredible. This is clearly a really ugly scoli. And a lot of times the universities will use this kind of stuff for big planning and help you get a better idea of what's going on. So it can be beneficial for that, way outside the realms of what primary care is going to deal with. But just so you got an idea of some of the applications there. MRI imaging, since that's obviously kind of the hot button, patients even with pacemakers think they need an MRI. So, you all have those patients who come in and like, what's going on? I need an MRI. Well, let's probably not good for your metal in your eye or your pacemaker. So let's talk about what's going on. Why are you here? Understand MRI. A couple things. Number one, MRI is a very, very, very powerful magnet that creates a magnetic field, and it helps align hydrogen atoms. And different tissues have different degrees of hydration and presentation based on the hydration of those atoms. When the magnet is, when they're in the magnet, the computer then utilizes those hydrogen atoms to give you the pictures that we see. When we talk about MRIs are typically, you'll see words like T1, T2, and stir. And for those of you who don't know, T1 and T2 are image sequences. That is not thoracic 1, thoracic 2. So T1, T2, and I'll show you the difference and what they mean here in a minute. But and stir is another common one. Yes, there are some other ones out there, and some of them are dependent on where you get imaging completed at. But just about invariably, every imaging center is going to do at minimum T1 and T2 imaging, and occasionally they'll do other images depending on what your working diagnosis is and what area you're getting an MRI of. So what are the differences? T1 shows fatty tissue as being bright or white, and water or CSF as dark. So there are definitely differences in the way it's going to look. T2 shows CSF or water as being a kind of a lighter gray or a whiter signal. And one of the easy ways to remember it is water is white on 2. So if you see CSF and you see white, you know it's a T2 weight image. The other thing is that anything inflammatory, swelling, bleeding, things like that are generally going to have a white or whitish appearance because it's more liquidy on T2 weight imaging. And on T1, it's going to be darker. So those are some of the differences, and I'll show you guys pictures of that in a minute. The other big thing is there's 0 radiation exposure. So, you know, a lot of patients go, well, I had an x-ray, I don't want all this radiation. Well, that's great, because MRI has no radiation. You know, you can put a pregnant lady in the MRI and scan them and it's fine. You can put a pediatric in the MRI and scan them if you can get them to hold still. You know, so when you get MR imaging, MR primarily gives you sagittal and axial reformat imaging. Occasionally you'll get coronals if you ask them, but overwhelmingly, at least from a spine standpoint, certainly in musculoskeletal, you can get coronal, sagittal, and axials. You don't have to ask them, they just come that way. Another thing I want you guys to understand is when we talk about how strong is a magnet, you know, are all magnets the same? And the answer is no. When you look at MRI imaging, the stronger the magnet, the more crisp the resolution, the sharper the pictures. So back in the day when I first started and we had 0.2, 0.3 Tesla magnets, they were okay. I mean, they were a lot better than CT, especially for soft tissue. As time has passed, we got 0.5 and 0.6 Tesla magnets, which were pretty good. Now the industry standards are at least 1.5 Tesla. And that's what's in most hospital settings, non-academic, but most hospital non-academic settings, most outpatient imaging centers are 1.5 Tesla magnets. And that's a really good run-of-the-mill average magnet. When you get into some of the academic centers, and definitely when you start looking at brain or neuro tumor workup, looking for things like MS or pituitary tumors and things like that, a 3 Tesla magnet is much more indicative, and generally it's going to be more in an academic setting. I don't know of any areas around here that has a 3 Tesla magnet as an outpatient type setting, but I can tell you places like Barnes Downtown and certainly St. Louis University and places like that will utilize 3 Tesla magnets pretty routinely for brain and neurotumor type work. MRIs can be open or closed bore, and I'll show you what that all means, because some patients will tell you, I have to have an open magnet. No, what the hell does that mean? You know, they just know they don't like being in a tight space, or they're too damn big to be in it, one of the two. Sometimes we'll get what we call STIR imaging, S-T-I-R, and it's a big acronym, but just if STIR is what the nomenclature is, which looks for inflammation, and it's a easy set of imaging to look at. So if you're worried about either something that's torn, ripped, broken, bruised, things like that, STIR imaging can show a lot of edema, because again, when things tear, when things break, they bleed, there's a lot of inflammation, and STIR imaging shows inflammation very, very easily on MRI, and it's easy to show to patients as well. So what are some of the advantages of MRI? No radiation exposure. It's okay to use in peds, but again, now you get into trying to get a kid to hold still. So sometimes I give them a little Michael Jackson juice and put them to sleep for a little bit. Pregnancy, A-okay. Excellent detail for soft tissue structures, even small soft tissue structures. Great for brain workup, even heart, liver, obviously spine. There's a special type of contrast we use with MRI imaging called gadolinium. Gadolinium is usually used in non-MSK musculoskeletal workup, with the exception of infections or masses. With gadolinium, you still have to check the creatinine. So what does that mean? So if you're going to get an MRI of the knee, you don't need contrast. You're getting an MRI of the shoulder, you generally don't need contrast. You're getting an MRI of the hip, you generally don't need contrast. You're getting an MRI of the gut, the heart, the chest, things like that, typically contrast is utilized. There's some arguments that MRI contrast is safer than ionodated contrast. I think the jury's out. There's certainly less reports of difficulties with MRI contrast than ionized contrast, but nonetheless, you still have to be respectful of that, of the GFR and creatinine functions. Nobody will do it without checking a GFR or creatinine first, which is reasonable. Most places will check it the day of to make sure that their creatinine is in an acceptable place. Some of the disadvantages, you got to be very, very still. If you're one of these people who's fidgety and moving around, you're going to get a lot of artifact, and it really cuts down on the quality of the MRI. I tell people it's almost like looking at it through Crisco, because you get an idea what might be there, but you just don't see the detail. It's the difference between an old black and white TV with rabbit ears out in the country versus a high definition plasma super duper picture on a TV. One, you get an idea what might be there. The other one, you really get the details. Metal artifact can definitely limit studies. And so, if you got a patient that has let's say they got a AAA graft, let's say they had an abdominal aortic aneurysm graft, and then you turn around and you want to get an image of the spine, you can do that, but the image quality is really going to be affected by that if it's a metal graft, if it's a metal AAA graft. So you have to think about some of the metal artifact. Is it going to really cause you problems? Now, that doesn't mean it's contraindicated. It just means it may decrease your visualization. There's some old spine hardware that was made out of stainless steel that really causes a lot of metal artifact, but we can still image it. We just can't see very well at the level where the surgery was. Metal stents in the heart, you can still get an MRI. It's just, again, you got to weigh out, okay, is there metal? Is there going to be artifact in the area where I'm imaging? So if I'm imaging the brain and they have cardiac stents, it's not an issue. It's not going to cause artifact. But if that person had metal clips up there, number one, you wouldn't do it because you're worried about pulling them loose. But number two, it would definitely cause some artifact in that region. So claustrophobia, big issue. Can't use it with certain implantable devices like cochlear implants are a no-go. Most pacemakers are a no-go. There are certainly some pacemakers out there that are MRI compatible. Patients know it. They have a card that says it. A lot of times it'll still get reviewed and looked at, and there's a book that Radiology keeps to look all that stuff up. Spinal cord stimulators, no-go. Pain pumps, no-go. What are some of the other implantables, like for Parkinson's disease and vagal nerve stimulators, no go. Those kind of things are absolute contraindications to MRI because the leads will get moved, and that could really cause a big issue. Another disadvantage is it's a lot slower than CAT scan. CT, you can whiz them in, whiz them out in a couple of minutes and really get some okay pictures of certainly solid organs and things of that nature. But to get good pictures on MRI, whether it be spine or organ or what have you, it's probably every bit of a 30-40 minute exam. As I said a moment ago, those are some of the no-goes with MRI. It is absolutely unequivocally A-OK for people that have had knee replacements to get an MRI. People have had hip replacements, get an MRI. People with spine surgery in the neck or low back, it's okay to get an MRI. Almost all orthopedic hardware is A-OK to get an MRI. Now, the thing you got to remember is somebody says, oh yeah, I had surgery. Oh, it's okay because it was spine surgery, you can get an MRI. Well, wait a minute, what did they have? Because if they had a spinal cord stimulator, that's no good. If they have an internal bone stimulator, no good. I mean, so you have to know what it is before you say it's okay. But I've also had patients who said, come in, and I said, well, I'm gonna get an MRI. And, oh, no, I can't have that. And I'm like, okay, do you have metal in your eye? No. You got a pacemaker? No. Well, I had my knee replaced. And I'm like, yeah, you got metal anywhere else? No, it's my knee replacement. And I'm like, some of their primary care told them, oh, you can't have an MRI because you had a knee replacement. And that's hogwash. Anybody with a knee replacement can have an MRI. So again, if you're not sure, ask the radiologist. But at the end of the day, I wanted to kind of give you some parameters of, hey, it's okay if you had a knee replacement. It's okay if you had screws put in your wrist for a broken wrist. It's okay that you had shoulder surgery or whatever to get those studies. Again, when you're not sure, then reach out and ask the rads before ordering it, so you're not wasting your time and money and all that nonsense. So here's a couple of different examples of MRI magnets. The far right magnet's really kind of the most archaic one, the tight, small, closed bore magnets. The upshot to those is they really gave you good pictures. The downside is if you look at that hole, there's only about 10% of Missourians will fit in this thing without grease and a shoehorn. If we look at the open bore, we kind of jokingly call these hockey pucks. You got a hockey puck above and below. That's still a little tight for people, but the sides being open allow a lot more tolerability. And a lot of these open bore magnets are 1.5 Tesla. So this is kind of a little bit more of the common one seen and certainly a little bit more well tolerated than the picture on the right. The picture on the bottom left, this is called a phonar, F-O-N-A-R upright magnet. And you think, wow, that's the cat's meow. That's what I like. And this one, the hockey pucks are on the side. You got one on this side, you got one on the other side, and the entire front is open and the patient's sitting upright. So there's nothing in front of them except the TV screen on the opposite wall. There's one of these in Missouri in, I think it's in West County, if I remember right. And they actually had a neat idea. These things have been around since about 2010. The problem is they're only 0.6 Tesla magnet. So they're very mediocre as far as detail is concerned. But if you have a patient that is so obese that they can't fit in a magnet, or they're so claustrophobic that they won't do the magnet even with some happy juice, i.e. Valium or Xanax or something, that may be an option for you. I've only had a handful of people who just said, no way, can't do any of that. And they adamantly request propofol sedation, which is a real nightmare. And most hospitals hate it because they got to have an anesthesia doc come down or a CRNA and give them some propofol and monitor them and yada yada. But that's a very limited scenario. If possible, get the open bore magnet or even a closed bore if the patient will tolerate it. These bottom ones, I really try to limit utilization of those. It just, the technology is not that great. The idea, the concept is wonderful, but the pictures just are not, they're okay. They're C plus on a good day. So couple pictures MRI. We saw the CT a few minutes ago, and you saw the great detail of the bone, but not so hot detail of the soft tissue. Well, now in this picture, here you see the spinal, the cord, you see the brain stem coming all the way down. The white stuff is the CSF. So the white is white, water is white on T2. So this is a T2 weighted MRI. On this, now you actually see the disc. Earlier we saw the bone detail, but we didn't see the disc. Now we actually see the disc. We actually see the spinal cord. And in this particular patient, the spinal cord looks great until we get to here. And then here we actually see spinal cord changes. And that's due to severe compression on the spinal cord. So if we had a CAT scan of the same patient, we wouldn't see those spinal cord changes. And that's really a significant finding. So, if possible, you really want to get the right imaging study for the right problem. And sometimes CAT scan is the right image. Other times MRI is the right image. And other times it'll be other things that we'll talk about here shortly. So I put an MRI of the cervical spine there, and I put an MRI of the lumbar spine on the opposite side. Again, so you can see the white, nice spinal fluid, the disc, nice and white. Remember when we talk about MRI and the hydrogen atoms imply if there's a lot of hydrogen atoms, it's more hydrated. So there's more water, more fluid. White is fluid. So you see all these nice big white plump discs. Those are well hydrated discs. That's why it's white on this particular sequence. If we look down at this disc and you say, wait a minute, that doesn't look like the other ones. That's what you're talking about. Degenerative disc disease, or DDD, implies that there's dehydration or desiccation of that disc, loss of hydrogen atoms. And so that's why it looks different on MRI, because it's more degenerative. It's not as plump. It's not as supple. It's not as good of a shock absorber, if you will. So these are just some common applications there. And then again, as we look at this, the ligament, you can see the ligaments, the interspinous ligaments are darker because it's a soft tissue, but it's not hydrated, it's not fluidy, it's not ripped. So that's what they should look like there. So just a couple of images to look at. And again, the bones there, you can see it, but it's not as good a detail as what you would get with a CT. So this is an MRI, what we call axial imaging. This is if we took the head off the shoulders looking down. So if we do that, you can see some really slick detail. We see the fibrous ring of the disc, the goo in the middle like the jelly donut, spinal canal diameter, all the little dots are the spinal nerves going through. This is around L3-4, so just to kind of give you an idea. This is a facet joint. We got a little bit of fluid in the facet joint, which is pretty normal. All of this muscle out here, from this little white thing over is multifidus and then longissimus. So you got two big muscle groups coming down through there. We see the psoas muscle, this big guy up here, and you got the other one here, big psoas muscle. We see the nerve roots as they exit here, the other one over here. And then you actually can see the arteries and veins really good. Here's the inferior vena cava, and then this is just as the inferior abdominal aorta is bifurcating, getting ready to split further to go down into the legs. So you get some really good detail there, and you can actually find a couple of, I've found a few AAAs on MRI because they'll actually include enough of the vessels here to be able to look at that and go, oh wow, that thing really dilates, and then you'll be able to diagnose a AAA if that's the case. So, and then I threw another one up. This is a little bit higher up at T12L1. When you get higher up, instead of all the little dots like we see here, when you get higher up, the spinal cord is a solid segment. So from about T12 north, you don't have all those little dots. It's just one solid cord, and the rest of the anatomy is pretty much the same. We can actually see the kidneys here. We can see part of the right kidney, or excuse me, left kidney and right kidney, and again the great vessels. And this is actually part of the diaphragm. We're looking down on top of the diaphragm as it makes its cut. So just a few things that you can see on the MRI. And again, this just happens to be one of many applications. So what are some of the indications? When we talk about brain, great for stroke, thrombosis, infection, tumors, AV malformations. Some people will use it for dementia workup, especially to look for any type of atrophy. Pituitary tumor, IACs or internal auditory canals, looking for tumors in the inner ear. Those are certainly ear, nose, and throat folks do that a lot. They'll get an MRI, including what they call MRI of the brain, including IACs, to look for any kind of tumors within the canal or ear canal. Spine, we've talked a lot about herniated disc, radiculopathy, myelopathy, MS, infection, tumors, cord infarct. I mean, that's where you're going to get that good soft tissue detail with MR. With musculoskeletal, joint pathology, shoulder, knees, hips, wrist, elbow. Those areas are such small detail that CAT scan is worthless other than for fracture detail. Tumor, soft tissue injuries, ligamentous injuries, tendinous injuries, you can look at it and say, oh, wow, that tendon's avulsed away, or that ligament is torn. That's what a rotator cuff is. You know, when you look at it, you can see a tear within the rotator cuff, whether it be the supraspinatus, infraspinatus, teres major, any of those. So, you know, you're able to look at those things. Another take home is when you talk about MRI imaging, on occasion, you'll do something that's a little odd if you're worried about a shoulder or a hip labrum. Occasionally, you can get a test called a CT arthrogram, and that's still done by the radiologist. The only difference is when they do the MRI, they inject contrast dye into the joint space to see if the labrum is intact, because occasionally that labrum is so small that if they have a small tear, even the MRIs miss it, then they read it as, oh, it looks okay, but yet the patient still has pain. And you can ask any orthopedist, you know, you go inside there and look around, and you're going to find rotator cuff tears and labral tears and things like that, and even meniscal tears that were missed. Most of the time you can pick it up, but there are times when you can't. Patients that have had prior shoulder surgery, MR arthrograms are helpful because there's going to be post-operative changes. It helps give you a better idea whether or not there's actually a tear or if it's just routine post-op findings. In the hip, you have a labrum as well. If you're worried about a labral tear in the hip, it's very beneficial to give contrast there, because I've had cases where MRI of the hip was ordered by somebody, read as negative. They acted like a labrum, they smelled like a labrum, ordered an MRI with gadolinium IV, labral MRI with gadolinium injection into the labrum, and all of a sudden it's a big labral tear. So that stuff can happen. So if you know, I said you don't need contrast, and that's true, you don't need IV contrast, but giving MR arthrogram in those scenarios can be beneficial if you're ordering it. If you're not sure, don't order it, and let the person you're referring to order it. Abdomen, pelvis, definitely IV contrast is helpful. Looking at hepatic and renal masses, pancreas masses, certainly workups for prostate carcinoma, cervical carcinoma, fistulas. Again, not real good with small bowel, large bowel, because it's collapsed. So if you're thinking more of a diverticulitis type scenario, or even colonic tumor, CT with oral contrast and or endoscopy, colonoscopy really is the best answer. But if you're working it up from a radiological perspective, CT with oral contrast is going to be the better choice from a colonic standpoint. Solid organ standpoint, whether it be hepatic, renal, pancreatic, things like that, CT is reasonable, but certainly MR is possible if they're not a CT candidate or you can't give them contrast. But if you do it with the MR, certainly giving gadolinium contrast is reasonable. Cardiovascular, looking at cardiomyopathies, intracardiac tumors, exquisitely rare. Big vessel anatomy, aneurysmal screening, vasculitis, things like that are all very reasonable. There is some use of this in tumor workup with breast, and even in some really off-the-cuff stuff, fetal anomalies, in utero fetal anomalies, doing the MRI to have a better idea what's going on. You know, at least can give an idea. It's not something I've seen in practice very commonly. I think that's probably more a tertiary center, but nonetheless, it's certainly an option because there's no radiation involvement. So when we talk about the T1, T2s I'd mentioned, I'll kind of hit that again a little bit. T1 weighted images are used primarily for anatomic evaluation. We look at T1s to say, what is the anatomy? Is the anatomy okay, or is it jacked up? What are we seeing here? Fluid signals are very low, signals are darker. Muscle is kind of that intermediate signal, which is kind of a middle gray, and then fat is more high signal or a little bit brighter, and that's T1. That's the picture on the top right here. So when we're looking at it, there's a lot of fatty tissue back here. So when we're looking at that tissue is more white because it's more fat in here than anything. And when we look at the muscle, it's more of that gray or kind of intermediate. That's this stuff. And then the water or the liquid is almost black or dark or low signal. So that's on T1 weight imaging. On T2 weight imaging, it's almost the opposite. Fluid is white, CSF is light. The muscle is still kind of intermediate, but the fat is a little whitish gray. Now, the one thing that is kind of easy about these is when there's inflammation or swelling or bleeding, on T1 weight imaging, it's going to be dark. So if we look at these vertebral bodies, we see this dark line through here. And then the same MRI on T2 weight imaging, we see this white signal in here. That's a fracture, and that's a compression fracture. If we look at the line going straight across, it's nice and straight across, and we see this kind of dip in there. That's a meniscus or a superior end plate fracture, and it has high intensity on T2, low intensity on T1. It's there on two different signals. That is absolutely unequivocally an acute compression fracture. And that's where MRI can be helpful. If you got an X-ray and it said, hey, fracture of T whatever, age indeterminate. We don't know if it's old or new. And if the patient has pain, there's the key. If they get a broken bone, they're going to have pain. If the patient has pain there and you see an abnormality on the X-ray, it's worth getting the MR to try to ascertain the acuity of the fracture. Then you can decide, hey, is this fracture recent? Is this something I have to take care of? Or is this an old fracture and life is good, have a nice day, leave them alone? So it makes a big difference there as to how you're going to treat that or not treat that. So CT or MRI, contrast or no contrast? Well, most joint studies, knees and shoulders, with the exception of the labrum, you don't need contrast. Again, consider MR arthrogram if looking for labral tears in the hip, especially in younger patients. MR arthrogram if they've had previous rotator cuff surgery, that can be helpful. Fracture evaluation, you do not need contrast. Non-union evaluation, you don't need any contrast. And again, that's primarily with fracture evaluation, and non-union evaluation is more with CAT scan than it is with MRI. Because again, it's a bony problem. So if you want to know, did bone A and bone B heal, CAT scan's a better test. So, but again, if you want to know, hey, do they have a rotator cuff tear? Do they have a meniscal tear? Those are small, soft tissues. The MRI is going to be better because it's better for small tissue detail and certainly neurologic detail. So contrast, regardless of MRI or CT, anytime you're looking for a tumor or mass, contrast can be helpful. Anytime you're worried about the itises, infection, cellulitis, abscess, those are beneficial to utilize contrast. Again, keeping in mind, are they safe from a renal standpoint? Using contrast and MRI if the patient's had prior surgery. So in spine, if a patient's had prior lumbar spine or cervical spine or thoracic spine surgery, and you want to get an MRI and they've had prior surgery, it's beneficial to get MRI with and without contrast. And why is that? Well, the contrast will help delineate the difference between scar tissue and new problems. So let's say Johnny had a herniated disc at L5S1. He had it operated on 5 years ago, 10 years ago. He comes back in with sciatica. You think he may have a ruptured disc. You're not sure. You're going to get an MRI. But he's had prior surgery. So if you get an MRI with no contrast, I guarantee you there's going to be some scar tissue around that old surgical site. Now the question is that new or a new disc herniation, or is that scar? How do you know the difference? Contrast will help delineate the difference. So if a patient's had prior lumbar spine, cervical spine, or thoracic spine surgery, especially posterior surgery, now I'm really getting technical, doing the MRI with and without contrast will help whoever you're referring that person to ascertain whether or not they have it or not. I've had numerous patients sent to me with MRIs of their back and they've had prior surgery, and it's pretty much a wasted study because I can't answer the question as to whether this is old or new, especially if it's on the same side. If their old surgery was on the left and their pain is now on the right, I don't care as much. That I can do without. But if their pain's on the left, they had surgery on the left, now they got new pain on the left, you have to have contrast to figure out whether or not this is old, new, or what's going on. So just one of those thoughts to keep in your head if you're going to image somebody, especially from a lumbar spine, cervical spine, thoracic spine. Again, when in doubt, ask radiology. Hey, this is what I'm worried about. This is their history. Can I use contrast, or does contrast even help you? And then when you're doing an MRI of the brain, especially if you're looking at it from an MS perspective, you need to utilize contrast because it'll tell you if there's inflammatory changes consistent with acute infarcts or acute demyelinization process. that can help ascertain and meet some of the McDonald criteria for multiple sclerosis. So if you really are thinking MS on a patient, then do either order MRI with MS protocol or MRI with and without AV contrast, evaluate for MS, so that they have an idea, they being the radiologist knows, what are you looking for? What do you know, is this patient just got headaches, or has this patient got neurologic findings that you're worried about, space occupying lesion, MS? What are you looking for? Because the more you can tell them, the more they can do to give you a definitive answer. I'm going to touch briefly on MRA, magnetic resonance angiography. This is primarily utilized just to look at vascular anomalies and anatomy. Can look at a lot of different places. We use MRI a lot in the neck, certainly in the brain, looking for AV malformations, carotid arteries. There's utilization in cardiac, chest, renal, hepatic, pelvis, and certainly extremities. Common things that you're looking for are aneurysm, atherosclerotic diseases, as I said, AVM, dissection, even in some cases PE. MRI can be utilized when CT angio is not a viable option due to either contrast or severe renal disease. So you got a person who's got a creatinine of 1.9 and you want to get a PE protocol CAT scan, probably not going to happen. You're gonna pickle their kidneys, in which case did you really make them bad and you didn't need to. So MRI is a good option when CT or CT angio is not a viable option. CT myelogram, not very commonly utilized outside of specialties. This is rarely utilized by primary care. I'm just going to touch on it briefly. You know, we were talking earlier, if you got a patient that's got a suspected herniated disc, but they have a pacemaker, and we just looked at CAT scan and said it's a terrible test for soft tissue, well, then how the hell are you supposed to figure out what's going on? There's a test called a CT myelogram, and CT myelogram is a test where the radiologist injects a contrast dye into the intrathecal space, into the back, and it can be done to look at the lumbar, thoracic, or cervical area. So what it does is when they inject it, they lay on a table and they move that table, they bank it head down, and they bank it left and right to get that dye to fill out. When that dye fills out, they take lots of pictures of it. And if there's significant delay in the fill, we know that there's constriction in that area. We may not know exactly what's causing the constriction, but we know that there's constriction or compression on the canal or even the exiting nerve roots. This can be very helpful when we're looking at stenosis, especially in degenerative processes. Again, we get excellent bone detail because the CT is there. And it's two tests at once. The myelogram is where the radiologist is injecting dye into that thecal sac, and they take lots of pictures. And then shortly thereafter, within a few minutes later, they then do a CAT scan, which includes axial, coronal, and sagittal reformats, which gives you then an idea of if there's any significant neurologic compression. What are the advantages and disadvantages? And I'll show you some pictures of this in a minute. So advantages of CT myelo is you get good neurologic detail. Even with hardware, you can get some good pictures because it's not a MRI, so you don't have the magnetic artifact. You still get a little artifact, but not as bad with MRI. So it can be helpful with neurologic detail when MRI is not the most optimal test. It's a good test to look at neurologic patency. It's a good test if the patient has implants. Let's say they have a spinal cord implant, they have a deep brain stimulator, a vagus nerve stimulator, or something else, and they're not MRI compatible. They have cochlear implants. I had a kid right now I'm treating, it's in his 30s, who has a cochlear implant, who has, I think, a ruptured disc. Well, MRI is not an option, so I got to get a CT myelo. It also shows pathology not readily identified by MRI. Sometimes the MRI underplays how bad something is. You get a better resolution of pictures with the myelographic detail if needed. And again, you don't have as much problems with motion artifact. Because they're not moving. CT is a very quick test in comparison to MRI. Now that I've sung praises of it, there's some disadvantages. Got to do it in a hospital. It's not an outpatient imaging thing. They don't have to spend the night, but it has to be done in a hospital. I don't know any outpatient centers that do them. It's invasive, meaning they got to get a needle stuck into their intrathecal intrathecal space, not epidural space, intrathecal space. So it's going into where the CSF is. You got to have an experienced radiologist that's done this before. Otherwise, if you got shit pictures, you're not going to get a good data. I've had a few radiologists outside our area that have tried to do them, and they get dye everywhere but where it belongs, and the imaging's worthless. The patient went through a procedure, and then I don't know any more than I knew when I sent them. It does not give good intrathecal or spinal cord abnormalities. Like we saw that picture on the MRI earlier where the patient had significant compression, and we saw the abnormalities in the cord. The myelogram won't show those abnormalities. It'll just say it's tight. It'll show you that it's tight there, but it will not show you that the spinal cord is hurt, bruised, swollen. It will not show you intramedullary tumors. If there's a space occupying tumor or intramedullary tumor, you will not see it or in there. You might be able to see a defect for intradural tumors, but you will not see any type of intramedullary tumors. Post-procedure, patients got to lay flat to avoid getting a spinal headache. You've heard of people that have gotten spinal headaches. Sometimes if they're really bad, they have to get a blood patch, and these are certainly complications that come along with this procedure. And then obviously there's some radiation exposure because you're utilizing CAT scan while you're doing this. These are some myelographic images. This is the very first thing that you'll see. They'll put the needle in, and as we see the needle here, it's attached to a syringe and a tube, and as they're beginning to put the dye in, this is what the dye looks like as it spreads out. And then here's a picture where the dye went in and it just got turned off right here. We call that dye amputation. And we know just at that picture there's something significant narrowing the spinal canal. In all probability, it's stenosis, but you know, we don't know if it's degenerative stenosis or from a herniated disc or what have you. But what we do know is something is really causing substantial compression at that area. You then get the CAT scan. The picture on the left is what we call a post-myelogram CT. So if we look at it, we see the bone detail really good here. We see the white stuff, which is the dye. It's represented, it's actually spinal fluid, but now it's white because it's got the contrast in there, and we see all the nerves. So we can really see that pretty good. If this patient had a pacemaker or implantable device, we can look at this test and see if there's anything hitting those nerves. Conversely, the picture on the right is the same CAT scan at the same level without contrast. So you guys can see this. You don't see anything here. So you get good bone detail, but you get horrible neurology detail. So in this case, not contrast, IV contrast, myelogram contrast is very, very beneficial here when we're thinking about a spine or spinal nerve or spinal cord etiology, as opposed to a non-contrasted, non-myelogram contrast. CAT scan is worthless in terms of looking at it for disc herniation, spinal stenosis, things like that. So just a couple of things. Hopefully you guys see the differences there. Again, I think this is more something left up to the specialist. If you're just not sure, hey, you know, this guy's got sciatica, but he's got a pacemaker. It's not MRI compatible. I'm just going to refer him on and let the specialist figure out what they want. That way you're not burning tests that you don't need. Plus, if you order the wrong exam, it makes our jobs a lot tougher to then, as a specialist in any situation, to order the other test, because the insurance says, well, wait a minute, you just got a CT. Well, I'm not going to pay for another one. Oh, wait a minute, you just got an MRI. Yeah, but I really needed this. Well, we're not going to pay for another one. So if you're not sure, ask or refer it on. Ultrasound. Most of you guys are familiar with this. Uses sound waves to generate imaging. Very little, a little bit of energy is reflected back, typically in fluid or less dense objects. It tends to be more black or dark gray on the imaging, or it's also referred to as hypoechoic. So if something's hypoechoic, it's usually either fluid or it's very, very soft. When something is very rigid like bone, the sound waves bounce off with a higher degree of energy, and it's hyperechoic. So it'll have more of a white or bright appearance on ultrasound like bone. Ultrasound probes are most of the time utilized externally. However, You certainly can utilize them transvaginally, transesophageal, and even in some cases transrectal if you're looking at, say, a prostate. So what are some of the advantages and disadvantages? Obviously, advantages, no radiation, great for point of care services, looking for things like DVT in the emergency room, using them for trauma to look for blood in the belly. It's a good initial test for vascular, whether it be arterial or venous. So if you're ordering an ultrasound of the lower extremities, you got to be specific. Hey, I'm worried about arterial claudication or venous claudication. Which thing are you looking for? Are you looking for PVD or DVT? Which is it? So you got to kind of tell them so they know. You can't just say ultrasound legs because they hurt. Well, wait a minute. Are we looking in the veins? Or are we looking in the arteries? Which highway are we looking at here? A lot of times used with pediatrics because you don't have any radiation exposure. The problem is in peds, first of all, you got to have an experienced person doing the test, and you got to have an experienced person reading the test. Secondly, statistically, and studies will show that appendectomies appendicitis are missed with a higher degree of frequency with ultrasound over CAT scan. So you really got to kind of weigh out those pros and cons as to what do you do. Ultrasound can also be helpful with aspiration and even biopsies of soft tissue. Although, again, I will tell you, I've had a case just recently where I thought a guy had an infected shoulder. I sent him for Okay, am I back? I think my thing fell out. Let's see. I just want to make sure you guys can hear me. Yes. Okay. I had a guy that had a shoulder aspiration because I thought he had a septic shoulder. The radiologist said, nope, there's nothing in the shoulder. I can't get anything. I did it with ultrasound and I know it's in the right place. I can't get anything. Well, the guy still went south and his shoulder was still killing him. I finally said, got to bite the bullet. I called one of the general ortho guys and sent him to the OR, opened it up. And the description in the op report is copious amounts of purulent drainage after exposing the shoulder. Now, the day before, the radiologist says there's nothing in the joint. The next morning, he has copious amounts of purulent material in the joint. So sometimes, you got to be a little careful about what are we getting into here. So, it makes it tough because you think, well, I did the right test, but I got the wrong answer. So you got to, again, treat the patient, not the picture. So what are the disadvantages? As I said a moment ago, very operator dependent. Limited in some ability in terms of where can you get to. It's hard to get to small areas and it's hard to get to people that are a lot heavier in terms of being able to see the detail well. Time dependent, a lot of experience, and again, less sensitive in obese patients. I threw a picture up of the ultrasound. This is a kidney, looking at it from a lateral view. Here's the renal cortex, and then the middle obviously is usually filled with urine. And so, as we said a minute ago, it's less dense, so it's hypoechoic or black. And I don't know why I just did that. It's hypoechoic, so it's black, as opposed to more dense and then even less dense. So you kind of see the differences in that. And then if there was some bone in that area, it would be more of a bright white, basically. Nuke Med, starting to fall out of favor. It's not done a whole lot. Use radiopaque tracers to tag certain molecules. Gamma cameras are utilized to then look for uptake in those areas. Decent when you're looking at the whole body or the whole skeleton, like if a person has a history of prostate cancer and you want to know, do they have metastatic hits? That's kind of what we're demonstrating on this picture here, is just multiple areas of foci uptake consistent with bony metastasis. Advantages, you can look at a big area in a quick sweep. The disadvantage is it takes a long time because you got to give the medicine, give the radioactive isotope. You have to wait a couple hours and then scan through it while it's being absorbed. You can get false negatives, especially if you're looking at it for fracture. The older the patient, the slower the uptake, so it can take anywhere as up to 72 hours before a bone scan is positive to discern a fracture. It's not a bad test if you're trying to figure out like osteomyelitis or stress fractures and things like that, especially if the patient has a pacemaker and they're not MRI compatible. This can be another option for you, but it's certainly becoming less and less of a common utilized tool with other options out there. Good option, again, if they're not MRI compatible. A lot of times you'll use bone scan in combination with CT to look for hot spots. Certainly, as I said a moment ago, osteomyelitis is a good one, hardware failure or lucency, occult fractures, Paget's disease, and then again, scout scanning for osseous mets, and even avascular necrosis. Again, you know, a lot of these things are, you can use MRI to look for, but in cases where you're not MRI compatible, or if it's just not the right test, like if I'm looking for Paget's, you know, bone scan's not a bad test. If I'm looking for osseous mets, like with prostate cancer, bone scan's not a bad test, but osteomyelitis, MRI is probably a better test. Hardware loosening, MRI is not a great test for that. You get too much artifact. So, you know, a lot depends what you're looking for. And these are good examples where, hey, if you're not sure, check with radiology and they can give you, give you the better answer. So you're not ordering a test that's worthless. And I think we have finally come to the conclusion. I put my email up here. If you have questions, certainly feel free to email me. If you guys want, obviously, I know we got done a little early, which is usually nobody complains about. If you guys want to unmute yourselves, please do and ask a question, or if you want to type it in, I can read it, whatever. Or you guys are just too tired after a very long day of information? I open the floor to you guys. Are you still there, or am I talking to myself?
I can hear you, Chris.
Okay, good. I just want to make sure I didn't like die and like I'm talking for a half hour and nobody listened. Okay. So a couple things in closing, guys. Number one, and some of this is redundant, but it bears repetition. The evaluations will be sent out later this afternoon by Derek. Remember, you need to complete your post-test for the continuing ed credits. The continuing ed credits should be sent to you electronically. That can take anywhere from 10 days to 2 weeks, generally speaking. And then a couple of other things, AMNP, their annual conference is coming up in October. It's actually October 9th and 10th. It's going to be a hybrid type situation. And for that, it's you can either go to Lake Ozarks at Margaritaville if you want to get out of your house for a while, or you can join us online. So it's kind of a combination type program. Another thing AMNP does a lot, and you don't have to be a member, although we would like you to be, are meet and greets. And a lot of these are done virtually, where we have somebody sponsor the talk. They give a short talk. You're able to introduce yourself, talk with other people in the chat room, keeping the whole social distancing thing going. Many a times there's prizes, attendance prizes passed out. It's a good way to network. And then if you're not sure about all this, there's actually a website for us. It's amnp.enpnetwork.com. And that has a listing of all the things that AMNP has coming up, and can give you more information. Or you can just Google Association of Missouri Nurse Practitioners, and it'll get you where you want to be. So there's actually a question: if I suspect ulcerative colitis or Crohn's, is CT with contrast good, or is it better to do a colonoscopy? I would say, I think a lot depends on how acutely sick your patient is, and if you know that's what it is. If you already know the diagnosis, I don't know that I would say a CT helps you at all. But if you had a patient presenting with abdominal pain and you didn't know that they had one of those things, I think getting a CT with oral contrast would be the right step, and then sending them to GI, at which time they're going to probably end up with a colonoscopy. However, if you have a patient that has underlying known diagnosis of UC or Crohn's, I think the CT is probably a waste of time. They're going to probably need to be directly scoped and monitored for any substantial changes. So thank you for that question. Any other questions, comments, concerns? You guys, please do those post tests and the and surveys, because that really helps us know what we can do better, and also helps us know what can we offer our memberships and people in the area. We got a lot of members that have numerous expertise. So if it's something that you have an expertise in, say GI, and you want to give a GI talk sometime, let us know, because there's always other people out there. We all kind of have a different hat to wear, and we all try to share our information. Most of them, actually all the members of AMNP on the board are volunteers. They do this just to try to help benefit and progress and move forward the agendas and the standpoints for nurse practitioners here in the state. So with that, thank you all for joining us, and we hope to see you either hopefully live sooner than later, and if not, maybe at some meet and greets or some of our annual conferences. And with that, if you have any questions, please feel free to email myself or Mr. Lefford. Any of us will be happy to help you, and thanks for joining us today. Have a great day.